Everyone. Welcome. We'll take a moment here to get some slides up to share some information with you as everyone is coming in. But thank you so much for taking the time to join us today. It's been about a month, I think, since we were together, and we've got a great topic, a great presentation for you today. So really looking forward to getting everybody in here and getting us going. Right. Okay, so as I mentioned, this is our next webinar here in our community webinar series. My name is Julia Wood. I'm the Director of Professional and Community Education, and we're on to webinar number 5. Today we're going to be talking about palliative care. And so before that, we're going to talk a little bit about the Lewy Body Dementia Association and some resources that we have that you might find really useful. So it's important to know our mission here, and that is to optimize the quality of life for those affected by Lewy body dementia. And to do this, we accelerate awareness, advance research for early diagnosis and improve care, and provide comprehensive education in events like this, and also compassionate support. So a few tips on navigating our webinar today. You can select the show captions feature on your toolbar at any time, and that will give you a screen of captions to read if that's helpful. You can use the resources icon, and that will pop up on your sidebar, and it'll show you links for different downloads and handouts and resources that you might find helpful. And then new for this year, we have a webinar worksheet that you can utilize, and that's also available on the webinar page on our website as well. So you can print that ahead of time and be ready to go. And that helps you kind of take notes and develop an action plan based on the things that you hear from the session today. Your questions can be submitted via the Q&A feature at any time, and we'll take about 15 minutes at the end of today's talk to address your questions from the audience. And then we ask that you please complete that survey after the webinar. And so for those of you who do it, you'll find that there's some content coming up soon that have been from some of your comments, even not just what you select, as far as topics you're interested in. So we really do read those. We kind of pore over them and obsess over them a little bit, but it's because we want to bring you the content that you want to hear about. And then also, as always, you will receive an email with a link for a recording to today's session in about 1 week. And in that email, you'll have a lot of resources available for you to download and use as well. So if you're looking for recordings of past webinars that we've done, you can go to our YouTube channel, LBDA TV, and you can see all of our past webinars from 2023 and 2024, as well as other recordings and events that we've done recently. Also, we have our Lewy Learning Center is available at any time for you to watch content on demand. You can watch these courses to meet your schedule and share them out with friends and family members and watch and rewatch as you like. And then also another option many don't know about is that we have a channel on Mediflix. And Mediflix is kind of like the Netflix of medical education. So they have great content on there on a lot of things, on diabetes, on Parkinson's, and then of course we have a channel. And one of the main offerings there is the film about Spark, Robin Williams and his battle with Lewy body dementia. This can be a great film if you're just new to kind of learning about Lewy, or you're trying to educate your friends and family about it. It's a little bit of edutainment, and Robin Williams is such a beloved figure that his story really resonates with so many. We also have a lot of other content on that channel as well for you to check out. And then, of course, we welcome you to our online community where you can find out about different events that we're hosting or that our partners are hosting out in the community. So you can follow us on all of those big social media channels that I don't do. No, I do LinkedIn, but most of this stuff is all foreign to me. And with that, I thank you so much for joining us and being here for today's session. And I will stop sharing and get ready to welcome our presenter. All right, so let me bring up my notes here. And we've got some survey questions that we want to do too before we bring him on. And so let's get to that. So A question I have for you, Rose, is going to populate this survey here. How long have you either been living with Lewy, and maybe you're a care partner or a person with LBD or symptoms, treating? So maybe you're a clinician or a healthcare provider, maybe you work for a nonprofit and you advocate for Lewy. So how long have you kind of been in this space, so to speak? Your options are 0 to 3 years, 4 to 8 years, 9 to 15 years, or more than 15 years. And so thank you so much. Those answers are pouring in. And this really helps us, just so you know how to kind of deliver our content, what level of education you guys are looking for. All right, so I'm going to share those results here. You'll notice that most of you, about over half, are kind of new within that 0 to 3 year window. We've got almost 30% of you around 4 to 8 years, about 10% with that 9 to 15 years, and just a little, just 4% for more than 15 years. Of course, we welcome all of you, but we just want to know who's in our audience. Okie dokie. So with that, let me go back to my script. Don't you know it? You go to print your script and your printer jams. It was a lot of fun. So today, our next question is, how knowledgeable are you with today's webinar topic? So we're going to be talking about palliative care and how you can access that. And Dr. Webb-Kay will do a great job today describing how it's different from hospice. And we find there's a lot of misunderstandings and misconceptions about palliative care out there. And so your options here, the webinar topic's pretty new to me. A little bit about this topic. I'm very knowledgeable about today's topic, and some of you might consider yourself more expert. Maybe we've even got some palliative care physicians or providers out there. And so let's end the poll and I'll share that with you. So it looks like the majority, so a little over half, feel like you know a little bit about the topic. And we did cover this topic back in 2023 with the International Neuropalliative Care Society. So that's another resource for you. About 38%, the webinar topic's new to you. We've got about 9% that feel really knowledgeable. And it looks like we probably have just our one expert with us today, and that's our presenter. So let me go back here to my screen I was looking at, if I can find it, and it's not going to bring it up now. Interesting. I can't read Dr. Webb-Kay's bio. There we whoop. Trying to get to his bio so I can read this to you. Here we go. All right, so I want to introduce our presenter today, Dr. Kevin Webb-Kay, and he specializes in palliative care and neurodegenerative diseases with a particular expertise in Parkinson's disease and Lewy body dementia. He established and leads a specialized clinic for palliative care in Parkinson's disease and related disorders. He provides neuropalliative care education through the Parkinson's Foundation, Lewy Body Dementia Association, and the University of Minnesota. Beyond his specialized neurodegenerative disease clinic, he practices both general inpatient palliative care and outpatient neurology. Dr. Webb-Kay believes that patients and families affected by neurodegenerative disease deserve high-quality palliative care, and he works to find opportunities and systems that can deliver it. So please use your reactions to give him a warm welcome. Welcome, Dr. Webb-Kay, sorry.
Hi, thanks for the warm introduction, and thanks to everyone for being here on a Thursday afternoon to hear about this topic. As you heard, I wear a bunch of different hats, but my main hat is trying to work on providing palliative care for things like Lewy body dementia, and that's what I want to talk about today. We're going to talk about the gap kind of as a specific thing, but also just thinking about how do these things fit together, what's palliative care, and how does it kind of fit into Lewy body dementia. So I don't have financial disclosures. I do, if you were in my clinic, we would always say, like, is it okay if we talk about sort of what things look like in the future? Is it okay if we're talking about what this disease looks like as the course goes on? And so I'm acknowledging that upfront, because I assume if you signed up for this webinar that's not that's okay with you, but just in the spirit of kind of sometimes people aren't ready for it or that's not what they want. I wanted to give you a heads up that that's part of what we'll talk about today. So my key messages that I hope you sort of take away and think about is that palliative care is an additional layer of support that we always say aims to provide person and family-centered care. And we'll talk a little bit, or I will talk actually rather extensively about how I think about what it means to provide person and family-centered care. And it really relates to the second point, which is that palliative care tries to address spiritual, social, psychological, as well as physical pain. That these things, particularly for something like Lewy body dementia, are really tied together in a way that maybe doesn't make that much sense to try to separate these pieces out, that we try to take things together in a big picture way. And that the needs of people affected by Lewy body dementia are different than other diseases. There are very specific symptoms that come up with Lewy body dementia. And as was mentioned in the warm introduction, palliative care is not hospice. And so I'll talk a little bit about those differences and try to make sure that people feel a little bit more comfortable with palliative care leaving the webinar than maybe they were before. So I always like to frame things as a case. This is not a HIPAA violation. I made this up whole cloth, but I think it rhymes with many cases I've seen and might have some resonance with you. So we can imagine Mr. Jones, who's a 75-year-old lawyer, who has maybe been kind of seen by a few different neurologists and kind of had these weird symptoms. Maybe it was that he was trying to read the tax report one day and it just kind of felt funny, and kind of maybe he was seeing something out of the corner of his eye, or his kids were saying, like, kind of seems like sometimes he's just not there, he's just kind of staring off. And it took a while to establish this diagnosis. Maybe the neurologist that he saw originally didn't know what to make of it, or they ordered some scans and didn't tell him any kind of helpful information. And so he's coming to see me, or if you're a healthcare provider, you can imagine him coming to see you for second opinion, or maybe they're even coming to see me for palliative care because they went to a webinar with the Lewy Body Disease Association and heard about palliative care and thought it might be helpful. So what is palliative care and how does it work in Lewy body disease? So palliative care is an approach to the care of persons living with serious illnesses that focuses on improving quality of life and reducing suffering through a whole person approach. This is sort of I like to start with concrete. Sometimes I can spin a tale. So I wanted to start with something very concrete. This is the definition from the International Neuropalliative Care Society that also is referenced in the introduction. And that's really what it's about. It's about trying to reduce suffering and thinking about people as whole people, right? And it goes back to what I was saying before. This is person and value-centered care. And we're going to talk about person and later value-centered, and how that really manifests in Lewy body disease. When people come to my clinic, if they're very skeptical about palliative care or just really uncertain, I say we focus on three main things: worries, or I sometimes say the normal ups and downs about having a serious illness like Lewy body disease. Sometimes talk about symptoms, and I'll say something like, maybe these are symptoms you haven't had a chance to talk about with your neurologist yet because there have been too many things, or maybe it's symptoms that don't seem to fit into any other bucket, like pain or nausea or lightheadedness or off times. And sometimes we talk about the future. So those are kind of how I think about what an actual clinic visit for palliative care looks like. And palliative care is not hospice. You'll hear that a few times. So palliative care, as it relates to Lewy body disease, has been studied and sort of codified by the Parkinson's Foundation. And I think, as many of you probably know, there's a spectrum and a relationship between Parkinson's disease and Lewy body dementia. And the reason I bring it up here is because the best evidence that we have about how palliative care works and what its effects are comes from a trial that was done for Parkinson's disease and related disorders, which included Lewy body disease. And so I wanted to bring in that model that the Parkinson's Disease Foundation came up with to sort of think about what it means and how it's really kind of operationalized in clinic and for real patients. So you'll see this figure, the 5 pillars of palliative care, a few times. And I am a lumper, not a splitter. So I think more things are in common than are different. And so you'll see me sort of reference these 5 pillars in relationship to some of the things that I think are most important about palliative care. And this is the fundamental framework that maps onto these 5 pillars. But I like explaining this a little bit separately, and then we'll kind of go back to the Parkinson's model. And the idea, I think the fundamental idea of palliative care is that people are complicated, and we want to understand people as people. That's what it means to be person-centered care. And one way to think about this is that if you're affected by serious illness like Lewy body disease, you don't just have physical symptoms. People are embedded in a social context. So we can imagine Mr. Jones, he's a lawyer, right? Maybe he was working until a year or two ago, and all of these symptoms have really piled up. Maybe he, maybe the way that he thinks about himself is that, all right, being a lawyer and being very mentally sharp has been really important to him, and now that's being threatened. That might be his kind of social pain, right? How does he interact and relate to the circumstances around him? And what's that like for him to have the experience of having a serious illness? Likewise, we can imagine psychological pain. What does this mean for my future? I'm really anxious about this. I'm worried about this. What does the future hold? And I think the thing that I had to learn most when I learned palliative care was this idea of spiritual pain, because it sounds sort of intimidating or maybe outside the realm of what we usually think about in medical contexts. But I think it's actually one of the most important things to understanding the journey of people affected by Lewy body. And the idea of spiritual pain is that it's when you cannot understand your own story. And so what I mean by that is we are always kind of telling stories about ourselves and making meaning out of the things that happen in our life. So I'm a physician now, and I sort of get to tell myself a story about, I get to give this webinar, and I'm passionate about advocating for palliative care and Lewy body disease and Parkinson's disease. But there will be a time where that's not true. And how will I tell a story about myself then? And so we can also imagine Mr. Jones not understanding how to make sense of what's happening to him and how to make sense of his own story. And that's really what we mean by spiritual pain. And we'll talk about that a little bit more. And then physical pain, right? I mean, pain is an undertreated symptom in things like Lewy body disease. And these things map onto the Parkinson's framework, right? Social pain, thinking about supporting emotional needs, supporting care partners. Spiritual pain, thinking about supporting spiritual needs. Physical pain, assessing and managing non-movement symptoms, thinking about the future. So I think of these as really related. And this model, I think we can say works because the trial, which we'll talk about a little bit later, was very positive, was very helpful. I also like to acknowledge in these presentations that palliative care is not all about thinking about what's going wrong. I think sometimes what we try to do is help people connect with the parts of their life or the parts of how they make sense of the world that still do make sense to them. And so thinking about, instead of total pain, total joy, what are the places where people can still feel connection, can still feel sort of plugged in to the values and the things in their life that are meaningful to them. So maybe it's just the comfort of being able to eat food that they like, or be in a place that's comfortable, working on those kinds of things, or being around friends and family, or giving to a cause that's important to them. Maybe it's making meaning through, telling stories or trying to pass things on. Maybe it is some sense of connecting with something bigger than yourself and finding ways to do that in the context of serious illness. And maybe it's just telling jokes or, having those kinds of experiences. And I think particularly in these contexts, trying to give you a sense of how do I think about what palliative care is and what do I think we should be aiming to give people affected by Lewy body disease. I think when we're doing our best, it's always my hope that we find some way for people to connect to these things as well, not just naming the things that are hard and difficult about Lewy body disease, but also thinking about what are the ways where we can find things that still provide meaning and still provide these things to people. Okay, so that's kind of an overview. I wanted to slow down a little bit going through a few of these things because I think of spiritual distress really as key. And if maybe of those 4 things, I think spiritual distress is maybe the most important to think about. Again, this is a definition that a chaplain taught me in my palliative care fellowship. It's when you cannot understand your own story. And when I first started my fellowship, I was very intimidated by this because it was like, well, I'm not a chaplain. I'm really nervous about talking about this or bringing it up because I don't want to get into someone's religion. I don't want to be offensive or sort of, misstep. But for most people, it's not usually overtly religious. It usually has to do with a loss of sense of self. And in other diseases, that certainly can happen. But I think in diseases where cognition and personality are affected, it is not a secondary consideration. This is what people live every day, both for the person affected by Lewy body disease, but also for their family and the people who love them. And as I said, that I think there are unique needs of people affected by Lewy body, the combination of fluctuations, hallucinations, and other psychiatric manifestations really push on this strain of trying to understand, how do I relate to myself as a person if I'm affected by Lewy body, but also if I'm the loved one of them, how do I relate to them? Who is this person and how do I make sense of that all? We can imagine Mr. Jones sort of saying, I was always a doer, right? I hear this a lot in my clinic. I'm not somebody who sits around. Well, now you are. And how do you sit with that? How do you live with that? I'm not the person I was before, or he's not the person he was before, right? I love doing, I don't know if it's a Minnesota thing. People love doing their lawns. I love working in the yard. Personally, I do not like that, so I don't relate to that, but people love working in the yard, and now I can't do that anymore, right? Or I loved being able to do my taxes. I loved driving my car. I loved going golfing, and now I can't do that. How do we put that together? I think these are the things that really feel like that tear in the fabric of how we put ourselves together. I don't know who I am now that I can't do, whatever that thing is for you. Pickleball, tennis, golf. I hear these things a lot. If trying to meet the hope that I give you some practical information, I'm going to provide a little bit of coaching. This is difficult for medical systems to process. Medical doctors, I'm a member of the tribe, but in general are not going to feel comfortable with this. It is it's an uncomfortable and sad space for people to be in. And I think there's a tendency to conflate difficult emotions and problems processing changes in your life, which I think is probably to a degree normative, with a medical illness like major depressive disorder. And this is a subtle distinction. But I think it's important to keep in mind. And as patients and family members, I often hear, if I'm seeing someone for a second or third opinion, oh, I saw Dr. So-and-so and all they wanted to do was push another pill on me. And what I have come to think that reflects is that doctors in general, or providers more generally, are, we want to be helpful and we want to the extent that we can, fix things. And, this is not something that we're going to fix in an office visit in 30 minutes. These are like deep questions that people are trying to figure out for themselves. And it may not be that this represents something called major depressive disorder that we think is some kind of problem with transmission of serotonin and will respond to 5 milligrams of Lexapro. This may be something bigger and deeper that isn't in the medical context. At the same time, it can feel invalidating or unhelpful not to have that be part of your discussion with your provider. And so sometimes patients feel like there's literature on this. Every time I bring something up with my doctor, they just prescribe another pill. And I think from the provider side, sometimes it feels like, or it could feel like, why are they asking me this question? I don't know how to fix it. Here's 5 of Lexapro, here's 25 of sertraline, because I don't know what else to do with it. And so this is something that I often just kind of give the air to breathe if I'm meeting with patients for the first time, because maybe they've never had a chance to talk about that with their provider. Maybe they've never experienced it in a medical context, but that can be powerful. That can be a way to start to build trust, start to feel like people are listening to you and kind of understand where you're coming from. This is really fundamental to what I mean by palliative care is meant to be patient and value-centered, right? Taking time to hear and understand where people are coming from before trying to ascribe a medical diagnosis to it. But this is challenging. This, just naming it, as people out there trying to navigate a medical system that doesn't often have a space for this, very challenging. I wanted to take a beat on overt religious distress if there are other healthcare providers in the webinar, or for patients too. As comfortable as I feel wading into the waters, this is when I start to feel like, oh, I'm in the deep end. I really need help. This is not something that I feel comfortable sort of wading in with. And if patients sort of bring this to me, I really sort of talk to them about, where are your sources of spiritual support, and are there people where you could talk about this with? This is more overt religious distress, right? Why is God punishing me? Yes, that's part of storytelling about ourselves, but it much more has to do with specific religious beliefs. And I would recommend, hey, Mr. Jones, that sounds really heavy. I wonder, like, where do you get your spiritual support? And is there someone you could talk to about that? For healthcare workers, if there are those people in the webinar, these are my tips. You do not have to fix it if you bring it up. So I say things like, boy, Mr. Jones, it sounds like when you lost the ability to do your taxes, that really just affected how you're thinking about your whole self. And that's been really hard. There's probably not a fix for it. I mean, we can try rivastigmine, we can try a cholinesterase inhibitor, but I think big picture, we're acknowledging losses and sadness. So take a beat before medicalizing everything patients tell you. It's okay sometimes to acknowledge loss and sadness, different than wanting to increase the dose of the cholinesterase inhibitor or start an antidepressant or start a stimulant. And if you're a provider or working in the healthcare system, don't underestimate the power of just mindful listening, presence, and providing validation in a medical space. It might be that the patient or family has never had validation in a medical space before. Maybe they've talked to family members, but they've never felt like a doctor or provider felt like that was important enough to take the time to go over. For family members, your well-meaning but stressed and uncomfortable provider may want to provide medicine in response to your spiritual distress. Don't feel like you have to take it. There's always this, we want to partner with our patients and patients want to partner with us. You can always just tell them, like, boy, I just wanted to bring this up because it's been hard. I don't necessarily feel like I need another medicine, right? Or if you're the family member, like, hey, Dr. Anderson, I think that's a great idea, the Prozac or the sertraline, but maybe let's just keep it in our back pocket. I'll let you know in 4 months or 6 months, kind of how things are going. And you can always ask if people have access to chaplains or social workers, or sort of what's available in your clinic. So I think I want to try to help you feel empowered to, before your next visit, maybe think about, like, do I feel consistently down and hopeless and helpless and, have feelings of fatigue and all of these things that might really look like major depressive disorder? Or have I lost the thread of my story and I'm feeling distress that I don't know how to put it back together? And I think it's totally valid and important to talk about that with your healthcare team, and they might feel uncomfortable. And you might have this conversation around starting a medicine. I sort of started talking about this, right? We can imagine social pain, that he's changing for Mr. Jones. He's changing social roles. Maybe he doesn't have his corner office anymore. Or he's someone who took care of his kids and now his kids are grown and he needs care. I don't want to be a burden on my kids. These ways in which our social roles change really are, again, something that happens in these cognitive disorders like Lewy body dementia that are really fundamental to people's experience. Similarly, there may or may not be a medical or medication approach to these concerns. We live in the medical system that we have, not necessarily in one that was designed for Lewy body disease. And so programmatic support throughout the medical system can be really limited. So I can prescribe expensive medicines, but I can't prescribe extra care for people. That's just the system that we have. And so social pain or problems with people's contexts don't necessarily always lend themselves well to the standard biomedical model of you have a problem, I'm going to prescribe you a pill, I'm going to see you in 3 months and we'll talk about if it's helpful. I think one of my themes would be understand, one, if the clinic where you're being seen has resources like a social worker who might help talk through those with you and see what you can access. And if it doesn't, trying to think of if there are other places, centers of excellence, research centers of excellence, bigger Lewy body clinics where you might have more access to those things. And then, for care partners, considering counseling, and for people affected by Lewy body, right? Considering counseling and support around those kind of transitions and changes, and thinking about how do I support myself going through this? How do I support my partner going through this in a way that probably is going to be outside of your 30-minute, every 6-month follow-up visit with your neurologist? This is similar. Psychologic pain, I think a lot about what does the future hold? Will I be okay? Will my family be okay? And similar to other themes we've talked about, sometimes, particularly in Lewy body disease, sometimes we're talking about real anxiety disorder. Sometimes we're talking about real psychiatric symptoms. But sometimes what people want is information. And the tone that I always aim for is empathetic but direct. People generally, not universally, generally want straightforward, accurate information about what to expect. And often that's some of the best treatments that we have. And sometimes there really are anxiety disorders that we should be aggressively treating. Sometimes there really are wearing off phenomenon. Sometimes there really are confusional episodes that we should be understanding and treating as part of Lewy body dementia. But we should also recognize when people really need guidance and information. And again, thinking about where are the non-standard medical things, supports that people can access. And also acknowledging that we have the system that we have. And if I could go back and change it and create more supports for people with neurodegenerative diseases like Lewy body, I would, but we have the system that we have. And so I think all of us working in this space are constantly trying to create our own Rube Goldberg mechanisms of like, okay, well, how can I get this person a social worker? How can I get them plugged in with somebody to help try to fill some of these gaps? As I talked about earlier, pain certainly can be undertreated in this population. And I think one of the key reasons and one of the key barriers is very often we're talking about trade-offs in treatment and decision-making. And that makes these discussions complex. It may be that it's appropriate to treat someone's back pain that they've had for a long time in the context of worsening Lewy body disease, for sure. And it may also be that the risk of that is worsening their confusion or their fatigue or making it so it's harder to get out of bed. That's a discussion that we should be having with the patient and their family, but it's complicated. And I'll give different examples more related to psychiatric illness in a few slides, but that's how treatment decisions really relate to patient and family values and how they view the disease and where they see things. I think we all agree if someone who's otherwise pretty healthy gets appendicitis, well, we should just treat it. But when we're facing much more complicated trade-offs, we need to think bigger picture. We need to involve families more. And we're going to talk about the specific treatment challenges in Lewy body dementia, which are the cognitive symptoms. Sometimes it's problems of speech or socially inappropriate behavior, personality changes, and these are hugely distressing to families, right? Often I hear if he only knew what he was doing or what was going on, he'd be mortified. Sometimes patients have insight into this, and that's difficult for them. Typically, families do have understanding that this is the disease, not him, and I think that's a comfort. But these symptoms are really what I think is some of the fundamental work of palliative care in this space. I think a lot of neurologists have experience treating this, and so I'm not trying to say like palliative doctors are the only people who should make these decisions, and certainly there are palliative doctors who would feel uncomfortable in this space. But what I'm trying to imagine is Mr. Jones, maybe, it's 2 or 3 years now into his course, and he's having hallucinations that are distressing to him. And he's tried the first line, therapies and treatments, which I have a slide on in a few slides. But now maybe you're meeting with your neurologist, or you're meeting with me, or you're meeting with someone in palliative care, and you're trying to make a trade-off between motor and psychiatric symptoms. Hey, I think we might be in a new place where we have to make a trade-off between how easy it is for you to move, Mr. Jones, and how distressing the hallucinations are. I wonder how you feel about that. And there's a medicine that has this risk of affecting how well you can produce your white blood cells, but maybe it controls some of these hallucination symptoms. And the key to try, from my perspective, the key to trying to make these decisions well is to first understand the patient and their family. And how people view these type of symptoms varies greatly and reflects important differences in religious and cultural beliefs. So if you imagine someone who's in this situation where day to day is becoming more challenging because of hallucinations, because of anxiety, because of kind of a fixed false belief about their surroundings, I have met many families who will say something like, Mr. Jones or my mom is suffering, or she's not there, we lost them before. And that family might be willing to make more trade-offs around how alert someone is. What are the risks of their falls? Whereas a family that says, I know she's in there, or I really value the time that we still have together, might make different decisions and accept different trade-offs. Maybe they value having more alert time while accepting that there might be more hallucinations. Or no, let's leave the levodopa medicine where it is to help mom walk, and we'll figure out the hallucinations later. Similarly, one of the key access, decision-making axes is a trade-off between safety and independence. So people typically want to be at home. They want, my patients say, as I suspect many of the patients affected by Lewy body disease on this call would say, I want to stay in my house as long as possible. And that typically means that you're going to be making a choice about a trade-off between safety and independence. Typically it's a worried daughter who accompanies them to clinic and says, yeah, mom, or in this case, Mr. Jones, I know you really want to stay at home, but what if you fell? Many families would say, we would rather he fall at home than never try. Or we would rather risk something happening at home than commit to a nursing home too early. But you can also imagine the opposite. I could never forgive myself if something happened at home and we could have seen this coming. Likewise, I think the providers can sometimes fall into a trap of putting our lens onto other people too much. People often tell me, none of this is up to me, right? This is all in God's hands, and I can't do anything that might shorten, the time that my dad has. And that is going to be guiding our treatment around how aggressive we should be and what risks and side effects people are willing to accept. to try to say, calm someone down if they're really agitated, try to control symptoms like hallucinations or pain, where the risk of sort of being too calm or too sedated is real, or part of what we're going to be talking about. How people view that state is really dependent on the family and really dependent on kind of where they're coming from. And that's what I mean by palliative care being value dependent. We can imagine someone affected by Lewy body disease and having many, different families are going to have different perspectives on how much that person is enjoying their quality of life, how much it's up to us to determine that, where to go from there, right? To understand the patient and their value system first, and then think about what are your treatment options, and then talk with them together about making choices. That's sort of like the key feature of, that's the key secret sauce of palliative care. We talked a little bit about the psychosis. This is a little bit more inside baseball. I'll just put this in the slides. If there are providers there, this is sort of my personal algorithm for how I think about symptoms of hallucinations and psychosis. I'll make the slides available. Just calling out that I think most of us who see a lot of Lewy body disease would say these three medicines, the cholinesterase inhibitor, Seroquel, and Nuplazid. There are insurance problems with Nuplazid. Those are sort of things we'd all try. And then beyond that, you really need to be having discussions with your patients and their families about what are the trade-offs? Where do you see the disease? How do you feel like things are going? Because those next lines are going to be dependent on patient values. My tips for healthcare providers: don't try to shoehorn this discussion into a visit if you've already covered other things. Make time to have a specific conversation around it. I know that's challenging. I mean, my wait times are super long. It's just hard in the current environment. But if you're not comfortable, start to develop your network of who are those people who you feel comfortable referring them to. For patients and families, before your visit, think about what's most important to you. I'm not asking you to be your own doctor, right? I think that's very unhelpful. Sometimes we offer too many things to people. We say, here's this menu option of choices. Good luck. But think a little bit about how, where you see things are. How are you thinking about where the disease is and what's most important to you? And it's very appropriate to tell your provider, I want to be sure that you know that being at home is the most important, and we're willing to take on some risk to do that. Or to say, the most important thing for us is to make sure we do not risk a fall or an unexpected illness. Those are going to lead potentially to different treatments, to different kind of approaches. And sort of these are things that I would encourage you to spend some amount of time thinking about or talking about as a family before your appointment. And then you can ask them, what do you think would make that most likely to happen? And always feel free to say, I recently saw a webinar on palliative care. Do you think that could help in this situation? Providers, it depends on the practice, but providers, I think, are still sometimes reluctant to bring it up. And you're always free to say, I'm really worried about how things are going. Could I see someone in palliative care? Do you work with anyone? Okay. So this was a trial. I'm not going to go into super nitty-gritty details, but this is how we know that it works, is they compared integrated palliative care with standard care, and the patient's quality of life was improved and care partner burnout was also improved. Things like the motor symptoms of Parkinson's disease, as well as depression and anxiety, were also improved. One of the takeaways for me, and one of the things that I think is important in my personal practice, is this trial, they did visits every 3 months with the team. Developing a relationship and developing trust with a provider or with a team or with the center, I think, is among the most important things that we do over time. Because there are going to be hard conversations. There are going to be conversations about trade-offs, and feeling like your doctor gets you, feeling like your providers are making good decisions and that you have trust in them. I think that's part of the secret sauce, not just, being able to prescribe a certain medicine or not. I talked about this a little bit. This is more for kind of, again, my personal practice. Most appointments, this would be true for really any palliative care though, most appointments are just like any other appointments that you've had. You go into a clinic and you go into a clinic room and you meet with a physician. And sometimes you might also meet with a social worker, or a chaplain, or a nurse. And hopefully they're providing you the opportunity to talk about your values, talk about what's most important to you. You might talk about medicines. You might talk about the future and maybe fill out forms. You might have referrals, but you're creating the space to try to have those conversations. This is I'm showing you this again to emphasize, right? I think about worries and anxieties, or ups and downs of having Parkinson's or Lewy body disease, where we're trying to support emotional and spiritual needs, support care partner needs. These changing roles, loss of autonomy, strain if you're, having changes in your jobs, social isolation, those kind of map onto social and psychologic pain, and this piece of supporting emotional and spiritual needs and supporting care partners, thinking about depression, anxiety, sleep, pain, hallucinations, all that stuff. And then, just taking another beat on medications, thinking about when is it appropriate to prescribe, and when is it just feel like people just keep throwing medicines at me and I'm not sure any of these really help, right? I hear that a lot from my patients. I'm taking all these medicines and I'm not really sure any of them are doing anything. So thinking about what are the benefits and burdens of that. I want to get to this and a couple slides on the gap and hospice, and then I want to leave time for questions. So I may skip a few things. These are the most common things that people ask me. I'll open the visit by kind of saying, sometimes we talk about the future, sometimes people have questions. And this is what people wonder about. What stage am I in? What should I be looking out for? How long can I be in my house? What is hospice? I have a specific request, whether that's, things I don't want or things I do want. How can I be sure that is honored? How can I try to have some of my wishes followed? And sometimes people want to know kind of specific prognostic information, but many times not. That's really an individual choice. So I won't share that information here. It's hard to navigate this. This is very difficult. One of my themes, right, is about loss of purpose, loss of identity, feeling like you've kind of lost the path, and that the biomedical system may not be helpful in finding it again. And that, yes, there are many things that are going to be important to learn from your doctor, learn from your team, learn from your center. And there's going to be many things where they're not helpful, just naming that. So I wanted to just take a second on what I call the gap, because that's in the name of the webinar. And so this is one of the areas where I think if you're caring for someone with Lewy body disease and you're thinking about what do I think probably the most important intervention that we do is, this is really where I think we make a huge amount of difference. I think early on, moderate disease for sure. But there is often a stage where people have had Lewy body for 3, 4, 5, 6 years. And they're starting to get to that stage where it just feels like my doctor's always pushing medicines on me and it doesn't really help. I have to go to the ER, but the ER doctor kind of blows me off and, or blows my loved one off and just attributes everything to Lewy body. Or I get admitted, my loved one gets admitted to the hospital, or I get admitted to the hospital and they just get confused and they have to go to rehab. And this is all just sort of like the totality of what the medical system is forcing on me. It doesn't feel like I'm getting that much out of it anymore. And this is like a really important time to think about palliative care resources. What I would identify is that the medical model that we have sometimes doesn't work that well for some of these diseases and some of these stages, where hospitalizations are more challenging. People either actually get into the cycle or worry about the cycle of, I go to the hospital, then I go to rehab, and maybe I get home for a week, but then something else happens and I have to do that all again. And the time away from home, family, the things that are most important is getting bigger, and that good time with them is getting smaller. Things that sometimes happen that herald, that alert me that maybe this is kind of where we're going, are things like falls, weight loss, worsening psychiatric symptoms. And thinking about care navigation and choices about treatments. Kind of going back to how I thought about and discussed the treatment of hallucinations. What's most important? I worked with someone in palliative care who would say, you should try to get the patient to tell you if they want to go to Denver or Phoenix, but don't ask them to fly the plane. You know, what's most important to you? Is it staying at home? Is it trying to control these symptoms, even if that means that movement symptoms are worse, even if that means they're sleeping more of the day? Or is it trying to say, what are the things that we can do to try to help someone be as alert as possible, to eat as much as possible? And different people with different backgrounds and different families are going to make different choices. This gap, this difficulty reflects limitations in the healthcare system. It just does. These are choices mostly unconsciously that we've made, but they add up to reflect that I cannot prescribe 5 hours a day of caregiving at home. Many of my patients need that more than they need me to prescribe them, their third trial of an antidepressant for anxiety. But I cannot do it, right? This is a limitation of the system. And I think when I meet with patients with Lewy body disease, they usually have already lived this. They're like, yes, I'm getting worked by the system and it's not working for me. This is not usually an insight that they haven't come to already. And it reflects that the way that we structured everything is for episodes of care rather than periods of extended debility. Even though I think that's for most people, we experience a period of extended disability. We just don't have a plan for that. It's just not part of how we've structured our system. These are some of the other symptoms as the disease progresses that we might talk about if I were to see you in palliative care. I want to leave enough time just to go through this. So palliative care is not hospice. Hospice is a federal program, typically through Medicare, so you don't have to pay for it. It's another common concern. It's through Medicare. It completely changes your relationship with healthcare. So you get a whole bunch of stuff. Medicines are delivered to you. You get nurse visits at your home or where you live, if that could be in a facility. Doctor overseeing your care, a pharmacist overseeing your medicines, a social worker, a chaplain, a massage therapist, a music therapist. These things all sort of come to you and support you where you are. But you give up certain things too. So, for patients with cancer, the sort of prototypical example is you stop doing chemo. I think for patients living with Lewy body disease, the major thing is how you feel about going back to the hospital. And for many people, not all, there comes a point where they feel like that's not worth it anymore. And I think that's when I really start talking to people about hospice. I think one way that providers screw this up, certainly I have stepped on a few slippery topics myself, is to underappreciate the cultural component. Progressive cognitive impairment or dementia is viewed very differently in different families. I like to say something like, tell me how you're thinking about your dad or your mom's, dementia or where they are with their disease. Because you need to meet the family where they're at. That's always our goal, is to try to provide the care that they want. And hospice provides support for anxiety, general quality of life, and spiritual support, but the data doesn't support that, hospice gives you better control of physical symptoms relative to if you were to stay in sort of the usual care outpatient setting. We are still figuring out palliative care for dementia and for Lewy body disease. We have this excellent trial that I mentioned before, but the interventions are very mixed. And this is something that, we're going to be working on throughout my career and throughout the next 5, 10, 15, 20 years, trying to figure out how do we get this to the number of people who need it. This is for if there are providers or people as part of teams in the audience. We cannot always just replicate a full program. It just isn't possible. And so how can we leverage what's available to try to grow what we do for people? So personally, I'm always thinking about can I wade into this person's spiritual distress a little bit more, and maybe we can have a connection, or maybe I can do something helpful there? Or is there a symptom medicine that I saw in a webinar that today's the day I'm going to try with somebody to see if I can help them without having to refer them, right? But on a program level too, maybe you don't have access to chaplaincy, or maybe you don't have access to a palliative specialist, but maybe you feel comfortable like trying one of the medicines for psychotic symptoms or for hallucinations. And maybe you feel like I can take that on. I can be that person in my group. And we can be sort of pushing our boundaries, even if we can't just whole cloth get one of these programs. So kind of wrapping up and thinking about for families, and it looks like maybe we'll have 15 minutes or so for questions or comments. So how can you help, right? Think about these things before your visit. Think about what's important to you. Recognize that it's uncomfortable for your physician or your clinician. You may need to sort of coach up to help them, right? To say no to a medicine if you're really think like, I don't think this is depression. I think this is that I'm sad in an appropriate way. If you can think ahead or name preferences for trade-offs, just tell them. You certainly can ask for palliative care. It might be that they don't have somebody they know or can recommend right away, but you can always ask. And try to describe what you want, even if you don't know what to call it or how to get it, right? It's not your responsibility to know all the medical terminology, but we want to hear from you. And I'm sure that your providers want to hear from you too about what would it look like? And it may be that starts a conversation about what's possible, but hopefully it does start a conversation. So palliative care is additional layer of support, person and family centered. Hopefully I've sort of talked through what I mean by that. Spiritual, social, psychological, as well as physical pain. Certainly feel like I've maybe hammered that. We've talked about the things in Lewy body dementia that are specific, right? That are different than cancer, different than heart failure, different than other conditions, and that palliative care is not hospice. I think that's my last slide. So I would be happy to sort of have a discussion or hear questions or comments, and I think we have some time for that.
Excellent. Thank you so much, Dr. Webb-Kay. We'll get set up here for Q&A because we got some great questions that came in, and you're getting lots of love down there in the reactions. And we got some great comments as well from people that really expressed appreciation for this fact that you leaned in and talked about that spiritual distress and some of those issues. So thank you so much. Let me get our questions pulled up here because, like I said, we had some really good ones. So this first one, I think you talked about, a little bit or kind of touched on, and this individual is in Canada, so it could be different. But I think the question overall is relevant in kind of who decides the choice of palliative care. Is it the physician that should recommend it? Is it the caregiver? Is there a certain, and they say stage of Lewy, we don't really have specific stages, but kind of when is it appropriate?
Yeah. There's not a standard of care right now. And I think that's one of the things that I think if I imagine how do I want life to look in 5 or 10 years, I think I wanted to find an answer to this question. I don't think we as researchers, I don't think the researchers know the answer to this, and I don't think the systems have a way to operationalize it yet. My rule of thumb is I think patients and families have a sense when they get to a place where the implicit sort of relationship you have with your doctor or your provider or whatever, where it feels like I come with a problem, you give me a medicine, we meet again in 6 months, where that starts to feel like, I'm not sure that's the right model anymore, right? Or where things feel like they're starting to get harder, or you're starting to have more worries, or you're kind of, I meet a lot of families where they have the sense that things are different, things are changing. I think those are the times where I recommend, again, starting that relationship. Can you meet with someone, even if it's not urgent or an emergency, so that you can start to build trust and build relationships?
Absolutely. I think that's a good know thyself moment. Absolutely. So question here about kind of hospice and palliative. So they sought palliative care for their father with Lewy, and as this was what they understood it was to be, and yet they were directed to hospice rather than palliative care, but he does still seem to have the same areas addressed. So kind of curious about, when they decide hospice versus palliative.
Yeah, and that's actually a great opportunity for me to clarify one other thing. So I sort of mentioned this like palliative care is a additional layer of support. One of the key differences between palliative care and hospice is the hospice is a program, kind of like I talked about. It comes with all of this stuff. Palliative care is not like that. You don't enroll in palliative care. You're not on palliative care. Um, getting or receiving palliative care is just seeing another physician, maybe a social worker, a chaplain, kind of having them as part of your care team. So that having been said, how might it have been decided, or sort of who decides and how does that work? One of the key things is eligibility, and assessing where someone is. I guess I'm a palliative provider. I don't do hospice. I was trained in hospice, but I'm not a hospice provider. It would be my preference that you meet with palliative care first, right? To have a discussion around all of the things that I kind of talked about in the seminar. How are you seeing things? Does it feel like hospice? You're ready for hospice? Does it seem like that makes sense for you? Because I have had a few patients where they're referred kind of directly, or they think they're getting one thing, and then it really does feel like, ooh, I what is this? I'm getting switched. No one's explained this to me. Does this mean that my dad's dying? How did this happen? So I think one is eligibility, and then two, sometimes people come in and what they say is like, I'm at a point where I want to be at home. I don't want to go back to the hospital. And I think when people describe hospice, sometimes we just say like, boy, what it sounds like is you're describing hospice, and why don't you meet with them? But I think sometimes people are referred for eligibility because they're describing it, or because maybe palliative care is not available and they did that instead. I'm not sure, but it sounds like that questioner's experience wasn't ideal, and wasn't exactly what we'd be hoping for.
Absolutely. Yeah. And another question here that kind of I think backs up to that too is it sounds like since it's not a program, they're asking if Medicare Advantage plans pay for palliative care
Yep.
versus hospice. Okay.
Yep. Yep. It's like if you were referred to your cardiologist, you wouldn't, and your referring provider thought it was appropriate, your insurance would pay for it. Yep.
There
Also,
you go.
very common question. So yes, it should be paid for.
Fantastic. And then this individual has a question that their local hospice provider also has palliative care. And is that normal that typically the same providers do both palliative and hospice? Is it helpful for that for them to have both?
Yes, that would be pretty typical. So the way that the board certification works is you're board certified in hospice and palliative medicine. So I'm board certified in hospice and palliative medicine as well as neurology. Um, as it happens at the institution where I work, the hospice and palliative are sort of separated. And I would say that's generally how it is, but it does not surprise me that someone who is the hospice director or works in hospice also has a palliative care practice. Um, and so many of my colleagues go between hospice and palliative medicine. So that's not surprising, and it's not a red flag. Um,
Okay.
that's a pretty common practice.
Sounds like a common overlap for sure. And then this individual says that someone in their local support group was refused palliative care by their loved one's provider. And then is that kind of a trend you see? Is there a way that you can push then to get it when you've gotten that refusal?
Um, I'm not sure about being refused palliative care. I wonder what I wonder more about the context. Maybe there's not someone in the oh, um, so sometimes there is not this was true until I was recruited to my institution. Sometimes there's not somebody who does it for a neurology clinic. Sometimes it's by specialty. Like they only have people who do palliative care for cancer. That would be typical. And they don't have someone who would see you if you have a neurologic condition. What I would recommend in that circumstance is, boy, Dr. Jones, it sounds like you don't have someone who does palliative care for neurology. Do you know of any other groups in the area who do have someone, or do you have someone you can ask? Because I don't think it would be typical that you would be refused palliative care, because there's not really too early. I mean, particularly for Lewy body, I think we would see someone at really any time along the timeline. But I can imagine that the institution just doesn't have the structure to see someone with Lewy. That would be unfortunately common. And so my advice would be, again, just to ask, and then to look to look at the Lewy Body Association and see if there's any. I was thinking about this before the webinar. Both the International Palliative Care Society, we don't have a sort of clearinghouse yet of people who do this, and I think that's a good project that I was thinking of. So I don't have a resource where I can say like, go to this website. There's a spreadsheet. You can find one within 100 miles, right? That doesn't exist yet, and so unfortunately, there may be some sort of pushing and trying to figure out how can I get access to that, and it might be limited, and that sucks.
Absolutely. And you guys, you can always reach out to our support services team. We have social workers and care providers who really can help you try to find that if it is available in your area. And so I know she's been popping the information in the chat there. You can call them or email. And if there is someone, they'll help you locate it. But, that is probably sometimes possible that it's not available. And this question is a little personal and to home for you. So this individual has a loved one who is a patient at Struthers Parkinson's Center, but they live in a care facility in Minnesota. So they're wondering how palliative care would differ in kind of a home setting, versus a care center.
Yeah. Because I would love to provide more services, but because I don't provide more services and can't prescribe more services, the care and sort of the meat of what we do is the meeting and talking through these questions, right? Like what are the major problems and issues that you're having, and kind of where are things and what kind of trade-offs would you make, and how, where do you see things? So it wouldn't differ between a care facility or being at home. Certainly I do video visits, and I'm sure many other palliative providers do video visits, because it reflects the reality of, like, a lot of our patients aren't in care facilities. And a lot of our patients, it is not trivial to drive across the metro and do another clinic appointment on top of all your other clinic appointments. But there wouldn't be a major difference.
I truly believe that the expansion of telehealth services was one of the silver linings of the COVID pandemic. And that expansion was really needed for a lot of people. So that's great. So this person, their loved ones at the VA, and they said that they don't have palliative care. And so, of course, being at the VA, they can see other providers. So she's wondering if she should request, through a primary network or a primary care doctor, or does she go directly to her Medicare Advantage plan to find palliative services? We kind of touched on this a little bit, but any suggestions there?
I don't have a blanket suggestion, because a lot of this is a bit patchwork. It depends. I know the Minneapolis VA is right, it's one of these huge VAs, and so there are outpatient palliative services within that VA. And I also can imagine the VA where I trained didn't have something similar. So there's not a one size fits all, and it may just take a little bit of finagling and working with the LBDA, or the case manager at the VA may also have some information about that. But I don't personally have like a blanket recommendation without sort of any other context.
That's good advice. Thank you. And then this one I think is related, but if you feel for whatever reason that you don't want to address it, that's okay. But it is, I think, a question that comes up a lot is, what is the rationale for putting someone with Lewy body dementia on a feeding tube? Is that something that comes up in palliative, more in hospice?
Yeah, I would say there's not a good way to address it in a few minutes, because it touches on so many of these different things. It's a highly, it's a very meaty topic, but I think it ultimately reflects deep concerns on either side about what does it mean to take care of someone with advanced illness. And sometimes people need feeding tubes because they have an isolated problem with swallowing, or they have some kind of motility issue, and otherwise they're quite highly functional. And I think that's a somewhat different scenario than someone who doesn't remember to eat or can't swallow because of progressive disease, or has some of those kinds of issues. I think the rationale is that you want to do everything you can and support them in this way. And I think for some families that makes sense, and others it doesn't. It's a really deep and rich and controversial topic. So I don't want to just stir the pot and walk away. But acknowledging that I think the rationale for people who would support it or families who would support it, it has to do with, well, this is how I'm caring for my loved one. How could I not feed them?
Absolutely. Absolutely. A topic for another time, maybe in the future. Another question here that I think
Certainly
is
is something
relevant.
we talk about in palliative care. It would not, like I think if that's something that's on your mind or coming up with caring for someone, and you have questions about it, or are you thinking like, how do I navigate this? That is like, bread and butter. But it should be an hour-long clinic appointment just to talk about it.
I definitely put some time aside for that one.
Yeah.
I think this is another very relevant question as well. When do you, but also probably not a blanket answer. When do you make the transition from the identified, person with LBD as being the ultimate decision maker to the family more making the care decisions?
Well, so there are, I think the rule of thumb that most of us use is set out in this article from 25 years ago or so. The it speaks to, do they have capacity? And to have capacity, you should be able to express a clear choice over time. So it should be the same answer if you ask them, Dad, do you want to do this medicine or this feeding tube or whatever, over time. They should appreciate the consequences of their actions, right? So they should have some understanding of, well, my doctor says if I do this, XYZ will happen. And if I don't do this, ABC will happen. And you should be able to reason through the choices. Well, the pros of this are and the cons of this are. I emphasize with families that people have capacity to make specific decisions. So you might trust your loved one with advanced dementia to decide what they want for breakfast in the morning, but not trust them to, sign a home mortgage. And there are going to be a lot of decisions that fall in between. And, I think for a while, it will be hard. You'll have to navigate those decisions decision by decision. There may be a point where you feel like, okay, Dad's at the point where, we're really making all of his decisions, and there can be specific criteria to assess competency and getting someone to always make their decisions for them. And that's a bit more of an involved process. But the rule, or the way that I would evaluate it in clinic, or if I was in the hospital trying to help a family, would be those things. Are they reasoning with it? Can they appreciate the consequences of their action? Are they expressing a consistent choice over time?
Absolutely. I think that's really, really good advice. And I know that's such a complicated and hot button topic. So thank you for the guidance
Yeah,
on
and
that.
also acknowledging that it, for the patient and the family, it touches on all of those things, right? We can imagine Mr. Jones, who's always been in control. Now he's trying to express that he wants XYZ, but you're realizing, boy, he actually doesn't appreciate the consequences of what that means.
Absolutely. You
Maybe
talked
one of those
about that.
really, really
Yeah,
hard.
that identification and that role and all of those things in the beginning that are so important and not to be underestimated. Absolutely. We had one comment that I want to finish off with since we've gotten through all of our questions. Thank you all so much. So this individual says, thank you so much for sharing this important information. She truly appreciates your support. It's been 4 years since her dad was diagnosed with LBD and he lives in Peru. There's so much information. There's not very much information about the disease there. And so they've been able to share this information and resources there, and it's really helped the medical team. So I think important to note that you're not just making impact for the families and caregivers here and healthcare providers, but really that's going all around the world. We see with our webinars. So thank you so much again for your time. Dr. Webb-Kay, I can't thank you enough. This was really, really a rich discussion. And I hope you've all found today's webinar informative, but unfortunately we're out of time. So on behalf of the Lewy Body Dementia Association, I'd like to thank you all for taking time out of your day to join us. And a special thank you to Dr. Webb-Kay again for sharing your expertise with our community. As a reminder, you're going to get that email in about 1 week with the link for the recording of the presentation, as well as the resources and links that we mentioned today in the webinar. We invite you to visit the landing page on our website to stay informed about upcoming webinars and access those past recordings. And Rose will drop that link in the chat for you now. I'm super excited about our webinar that's coming up next month called Empowering Care Partners, but there'll be a lot of tips in there for you guys with Lewy too. And so we're going to talk about transfer and cueing techniques for Lewy body dementia. And this is going to be live on Monday, June 9th at 2 p.m. Eastern Time. It's going to be presented by my former colleague and who I consider to be my mentor, physical therapist Heather Cianci. She has been in this space for over, I think, 25 years now. And this is going to be a very practical webinar designed specifically for care partners and paid caregivers of individuals living with LBD. Heather will provide you with a few essential strategies to improve the quality and care of the care and support you offer. You're going to learn some safe and efficient methods for transferring individuals, reducing the risk of injury for both you and the person that you care for. And that's going to help make those daily tasks easier and more manageable. And so Rose is going to drop the link for the registration page and that, but you can also visit that landing page as well. Finally, please take a moment to complete that survey because I got the idea for this upcoming webinar from a comment from someone in that survey. And we look forward to seeing you all again in June. Thank you so much for your time and attention. Thank you, Dr. Webb-Kay.
Thanks again.
Bye, everyone.